All right, you guys. Well, it's the top of the hour, so I'm going to go ahead and get us started. Welcome to everyone who's joining us from our YouTube channel, to our Facebook channel, to TikTok, to Instagram. I see a lot of new names as well as a lot of recurring names. So I love to see you guys joining me and really following this free webinar series that we have for you here at Archer, where we really try to put in really high quality content that's going to help you not just to pass your boards exams, but really the most important thing, to be confident clinicians when you enter clinical practice. And even if you've been in clinical practice for a little while and this is just stuff that you need refreshers on, we really want to help support you in your clinical practice. So for those of you joining us for the first time, yes, these are live. So any questions you ask me, I'm going to try to do my best to answer them in the various platforms that are streaming right now. The best way to join, really, we're trying to get everybody to join us via Zoom. And the reason for that is because we've been now accredited by the ANCC. So if you join us via Zoom and you stay for a full hour, you will automatically get one contact hour in your inbox. It'll generate that for you at the end of the webinar. We are scheduled for an hour and a half. And the reason why we started doing this for our lectures is because we really found as instructors that there's just so much content, and we want to make sure that we provide that content for you guys at a nice pace so you can really understand it and take it in and process it instead of just rushing through it. So we do have an hour and a half just to give us that little play, that little window if we want to go beyond the hour. But really, if you can only dedicate the hour and you have to hop off after an hour, that is sufficient for getting that contact hour. So before we get started, I do have a disclosure slide that I'm going to go over today. Today, we're going to go over EKGs or ECGs. My disclosure is that, yes, we're accredited. What I just said, you have to stay for that full hour. And then we have no relevant financial relationships with any of the content that I'm going to present to you today. This is really just content that I've put together for you based on my clinical experiences. We're going to go over a case study. And also I've thrown in some test prep questions in there as well, but there's no commercial interest here. Nobody has paid me money to advertise like an event monitor or Holter monitor or anything like that. So our learning objectives. So first, we're going to identify the parts of an EKG. I find that a lot of these EKG lectures, especially I remember as a new grad, I felt really overwhelmed and intimidated by a 12 lead EKG. Knew the rhythms. I studied them. I was ready for the boards. They really on the boards only test you on the very basic abnormal rhythms that you'll see, the arrhythmias. But I found that like once I got into clinical practice, that 12 lead really intimidated me. And so we're going to break it down into the fundamentals before we get into those arrhythmias so that we're all on the same page. That's the way I taught myself. That's the way I practice. And that's how I felt confident really interpreting those 12 leads. So that's my goal for you today, is to really feel confident in moving forward and really practicing those 12 leads as you are entering clinical practice or about to enter clinical practice. So we're going to identify those parts of an EKG, talk about those common abnormal findings. We're also going to explain what it means, right? So I'm going to break it down into what's happening in the heart and how does that translate over to that EKG reading. So you're really going to be able to assess and diagnose what's going on with this patient and then appropriately manage them, right? Get them to that appropriate level of care that needs to happen or it doesn't need to happen if it's something that's reassuring. So we're going to talk about that and then also demonstrate understanding of those warning signs and refer to that higher level of care. So one is something really concerning, we need to get them to a higher level of care. So those are our learning objectives. So for those of you who've joined before, you know I love this Slido tool, and our first poll is already live on there. You'll see who's in the audience today. And so for those of you who aren't familiar with Slido, you can go ahead and scan this QR code. It'll take you over to the poll. If you can't scan a QR code because you're on the phone, you can technically go into slido.com when you're on your phone and be on it at the same time, or like an iPad. But some people don't like that. Maybe they want to do it on a computer. You can go to slido.com and just put in the hashtag ECG4NP. It's my little clever hashtag for it today, and it'll take you to the poll. What I really like about the poll is that it's anonymous. So when you answer the questions in the poll, I can't actually see your name, and neither can your peers. So it really gives you that freedom to just take a guess, a shot in the dark, and just not worry about feeling judged. Not that we're going to judge you anyway, but I know sometimes that holds people back. You can also see your peers' responses, which is really nice. So I really want to get a lively discussion going in Slido today, especially for those joining in other platforms. I am going to do my best to look at all of the different restreaming services, but really Slido is where my attention is going to be during this webinar. So if you want to interact with me, definitely get on to Slido with me. And for the first couple of polls, it's really just to practice how to use the Slido poll for those of you who it's new. So here I can see one person has already put in a response who's in the audience today. So typically for this starter Slido, I always like to see, are you an RN? How many years have you been an RN? Are you a nurse practitioner student? Where are you in your training or your nursing career? Because that really helps me kind of tailor where I need to tailor the presentation or the webinar as well. So then you can see people are participating. So I've got 3 people typing, 4 people have sent in responses. So really, it does not show your name at all. And we can really interact with each other this way on a remote platform. So I see some people are FNPs from Florida. Some people are joining from New Mexico, Connecticut, NP graduate. So are you a new grad? Are you an experienced NP? Let me know. I see some new grads studying for your boards. Good luck. It's an exciting but nerve-wracking time. I see some RNs and FNP students. Tell me how many years you've been an RN. I always love to hear about that. New grad RN, that's awesome. Good for you for being on today's webinar. This is really going to help you when you're in that clinical setting. And then if you want to go on to advanced practice, you really are going to be very comfortable with these 12 leads. So that's awesome. So a lot of RN and FNP students either joining us nationally or abroad. I saw on our YouTube channel some people from Kenya. I also saw, where else did I see, from Nigeria. So that's really exciting. We get people not just domestically, but internationally joining these free webinars too, which is awesome. We're all nurses trying to serve our patients and help each other within this community. And that's the community that Archer really tries to foster. So I love to see that. Some people from Nepal, NPs studying for retake. That's awesome. We get a lot of NPs coming to us asking for help because they're sitting for their boards again. We'll talk about the SurePass guarantee and the SurePass method that we have here at Archer, but we've helped a lot of NPs pass their boards the second time around. So that's awesome. I'm so glad that you're here today and you're trying again. That's really great. Okay, so our next poll, let's see. We have a word cloud. Well, we talked about where are you joining from, but you guys already put that in. And I'm trying different types of polls so you guys get a little bit more confident in how to use them. This is one of my favorite polls, and I'll ask again at the end of the webinar. It's a scale of 1 to 10. How confident do you feel interpreting these 12 leads? I love my emojis. For those who know me, know that I really love my emojis. So as opposed to 1 to 10, really the crying emoji is at 0. We're not feeling confident at all. And then we have the hearts emoji, feeling very confident. So I see some people saying not feeling confident at all. Honestly, that's how I felt entering clinical practice. And it's a scary place to be. So I get it. And I applaud you for seeking out that education, because if you don't ask for help, if you don't look for it, it's not going to happen automatically. We do not want to rely on those computer interpretations, because you do have to sign your name onto that 12 lead and say that you interpreted this. So it's really important to make sure that you understand how to interpret these 12 leads. And I see some people fairly confident. That's awesome. We're going to see if we can get you guys back up to 10 by the end of the webinar. If not, that's okay. We'll do it again. We'll do another webinar. That's all right. And then my last poll, this one's an interesting one, but how many of you have had the opportunity to place a 12 lead ECG on a patient? So do you do it all the time as an RN? I know I have some RN and FNP students. Have you never in your life placed a 12 lead? Maybe you've done it a couple of times, either in your clinical rotations or as an RN, but how many of you have actually placed a 12 lead EKG? It's like a lot of you do it all the time. That's awesome. Maybe a few times here or there, never in your life. But a lot of you actually have placed those 12. It's such good experience. That's great. That's awesome. And the reason why I asked that when we're talking about EKG basics, the placement of the 12 lead really matters. When I was entering clinical practice, I had never placed a 12 lead. And then as a clinician, you either have your medical assistant placing that 12 lead, or if you're in a bigger hospital system, they go down to the tech and they get their EKG done by a technician. So I never really understood the importance of knowing about placement of the 12 lead in terms of interpretation until I really started diving deep into how to interpret these 12 leads. So awesome that you guys have that experience. Don't worry if you don't have it. I encourage you to play around with it if you have the opportunity in clinic. All right. Oh, and I told you the answer. Why does the placement of the 12 lead matter? Let's get into the content and then we can also go into that. But you guys can answer that check if you are faster than me. All right, so let's talk about EKG basics. So 12 lead EKG placement, we've been talking about it. What does it mean? So there are 6 chest leads, what we call them, the V1 through V6, and then you have 4 limb leads. And the reason why it matters is because that piece of paper that it's printed on, that graph paper, is actually the recording of that electric impulse from the heart. So when those heart muscles contract, that electrical stimulation is actually recorded on that graph paper. So you really want to understand what you're seeing as it correlates to what's happening in the heart, and we'll talk about that. We'll talk about depolarization and we'll talk about those skin electrodes. But remember, those skin electrodes are positively charged. And as that positive charge is going through the heart, that's when you're going to see that upward deflection on that EKG. As it moves away from the electrode, you're going to see that downward deflection. So the placement really does matter. And sometimes, and I learned this the hard way, if you're seeing something funky on a 12 lead EKG, you want to make sure the placement is correct and go back in and do the placement yourself if the patient's right in front of you and you have that opportunity in your outpatient practice. So with the electrical conduction system, let's talk about the basics. Where does it start? Remember, the SA node, that's our pacemaker, right? That is our primary pacemaker. That sits in that right atrium and it sends out the signal, or the electrical activity starts there. And it goes across the 2 atria, the right and the left atria, and really starts that depolarization process, meaning the atrial contraction. And then it slows down a little bit when we get to that AV node. And then our AV node is our backup pacemaker. That's like your backup generator on your house, right? The power goes out, the backup generator kicks in. It may not be as strong as the initial power, but it's something to keep the power going, right? That's how I want you to be thinking about the AV node. That's your backup generator. The reason why it's our backup is because that SA node, that's your beats per minute. It's about 60 beats per minute, 60 to 100 in an adult. With your AV node, that's your ventricular rate. That's about 30 beats per minute. So you're getting some cardiac output, but really this is our backup generator. We really want that beats per minute to be more in that normal range of 60 to 100. So as that SA node sends the signals and you get the depolarization in that atria, then it slows down and goes to that AV node. Then the AV node passes the signal down that bundle of His and into that left and right bundle branch block so that you get that ventricular contraction or ventricular depolarization. And then it goes through the loop all over again. How does that look on your EKG? Remember, let's look at the parts of an EKG. You have the P wave, you have your QRS, and then you have your T wave. So your P wave is that atrial contraction or atrial depolarization. That's that SA node firing off. You get the signal or the electrical activity going across both atria, both the right and left, and you get that atrial contraction. And that is your P wave. Then when it goes through the AV node, it's going down that bundle of His into that left and right atria. That is your QRS complex. That's your ventricular depolarization or contraction, right? You're getting that contraction of the ventricles. And then your T wave is that repolarization, meaning your ventricles are relaxing and the charges are going back to negative charge on those cardiac muscles, right? So again, positive charge as a wave kind of going through, and you see that atrial contraction with your P wave, you see that ventricular contraction with your QRS, and then you see that ventricular relaxation or repolarization with that T wave. So these are all our parts of an EKG. So how does that look on graph paper? So the reason why we get graph paper is because now in clinic, sometimes it just pops up on the computer. You can print it out, but all these little boxes mean something, right? They're indicative of time. And so the reason why it matters is because you really need to know, is this something that's falling within that normal interval of time, or is there an issue in this conduction system, right? So we take a look at these little small boxes. I'm gonna sit down. These little small boxes, so 0.04 seconds for each of those tiny little boxes. And so if you count them out, you get 5 of these little boxes, 1, 2, 3, 4, 5, within these bigger, darker lines. So 0.04 times 5 is 0.2. So all this is happening really fast, right? It's happening in 0.2 seconds. You count out all of these boxes. So 1, 2, 3, 4, 5. 5 times that 0.2 is 1 second. So this is a 1 second strip that we're looking at. And within that 1 second strip, we have our P wave, we have our QRS, and we have our T wave. And so with the P wave, we're also looking at that PR interval, right? That's the start of the P to the start of that QRS. That's our PR interval. And that's really normal. It's going to be between 3 to 5 boxes. And you'll get a lot better about looking at that when you're interpreting it. But the reason for that is because those boxes, again, stand for seconds. So 3 to 5 boxes is about 0.12 to 0.2 seconds. So that's a normal PR interval. You also have your QRS complex, and we'll talk about narrow versus wide QRS complex, but your QRS complex should really be under 3 boxes, and that's under 0.12 seconds. And then you have your T wave, and we'll talk about looking at inversions and ST elevations when we get there. But you're looking at your T wave, and then you're going to look at that QT interval, right? So that Q, it's from the beginning of the Q to the end of the T. And then you also have your ST segment. So when we're looking at ST elevation or depression, this is really the end of the S to the beginning of the T. We're looking at this area right here. So those are our parts of the EKG that pop up on this graph paper. And the graph paper really does help us to make sure that everything falls within that normal interval. The other thing that I want to talk about is that upward deflection. Remember, we were talking about lead placement, right? Those leads are positively charged. As the electrical conduction system starts with that SA node and that wave of positive charge goes across those cardiac cells in the heart, what ends up happening is when you have a positive electrical impulse going towards a positive skin electrode, that 12 lead, then you're going to get that upward deflection, right? And then when it moves away from it, you're going to get that downward deflection, moving away from that positive charge or that electrode. Let's see. I'm going to launch our next poll, which asks, what do you guys think about that QT prolongation? I want to talk about this, and we'll get into this a lot when we're talking about in today's lecture, but what can a prolonged QT interval potentially lead to? So why are we looking at all these intervals when we're looking at the parts of the EKG? Okay, I see a lot of typing, a lot of thinking. A lot of good answers. I love that you guys are trying. This is great. So arrhythmia, yes. What type of potential arrhythmia? I see torsades in there. Good for you. That's a very specific type of ventricular tachycardia. But absolutely, a prolonged QT interval can potentially lead to dangerous arrhythmias like ventricular tachycardia, one particular type, which is torsades de Pointes, which we will talk about. So awesome, awesome job. Remember, what are some drugs that can cause that prolonged QT interval? I'm going to go to that poll. But what do you guys think? And this is a select all that apply. What are some drugs that can cause that prolonged QT interval? What do you guys think? All right, I see one person's put in the response, 2 people, 3 people. What do you guys think? Antipsychotics, antidepressants, antiarrhythmics. antibiotics? What do you guys think? Some typing, some thinking. Yeah, this was a trick question because all these classes of medications can potentially cause prolonged QT interval. And the reason why I bring this up is because they're not always going to cause it. But if you're really looking at your 12 lead, you're looking for that prolonged QT interval, and you have a patient that you're treating with, say, azithromycin or a Z-Pak, which a lot of providers give pretty readily these days, that is a medication that could potentially prolong the QT interval. So this is why I really stress not to give patients an intervention that you don't think is necessary just because the patient is pressuring you to do it. All these medications do have side effects. Fluconazole can cause QT prolongation. What else is really commonly used? I was thinking about it. Lexapro. How many patients do we start on Lexapro? We really need to be watching for this prolonged QT interval. So it's not just antipsychotics, absolutely, but also our more common antidepressants, antibiotics that we use to treat certain common infections that come into the office. We can see this prolonged QT interval with those medications as a potential complication. So absolutely, and I want you guys to be mindful of that as you're prescribing. All right, moving on. So just a quick pause here. We talked a little bit about that sure pass, but what does that sure pass mean? For those of you who are either getting ready to sit for your boards or you're here because you did not pass the first time and you're getting ready to sit for a second time, we have a sure pass package, which is a pass guarantee. And what that bundles in is our question bank. We have over 1,600 questions that are simulated to be test style. And there's a free trial on it. I'll be pulling a lot of those questions into today's webinar so you can get a little taste of what that is. But I like our question bank because it gives you the opportunity to really practice how that information might present on the test. And then we also give you the rationale. So if you practice these questions and then read the rationale, you really can identify a good study plan to go back and really study areas where you may have some knowledge gaps. That is the most important thing. We're not studying to memorize. We're really going back to identify our knowledge gaps so that we can be safe and effective clinicians. So our QBank helps you do that. We do have readiness predictors on that, meaning that if you take, it'll give you 75 questions. And if you take the exam, it'll give you a prediction of whether you are ready to sit for your board's exam or not. Our Sure Pass package, we recommend that you go through and watch some on-demand videos, take about 25 to 50 questions daily, about 2 weeks leading up to your board's exam, and then take those readiness predictor tests. And if you are scoring high or very high on those readiness predictor tests, about 4 in a row, that really indicates that you are ready to sit for your boards. If you're kind of not scoring there yet, you need to definitely go back and watch those videos, get into the content, read the rationale, and fill in some of those knowledge gaps. So it's a really nice tool to play around with. If you're not ready for the whole pass, which bundles in the question bank and the on-demand videos and a live review, as well as a mentoring session with one of us, you can really pick and choose a la carte, which is nice. You can just do the question bank, start with a free trial, see if you like it, and then you can bundle in that on-demand video. We have over 16 hours of content. And right now on our on-demand video, we have really nice advanced clinical skills videos that our chief nursing officer recorded. So things like how to do a speculum exam, how to use an otoscope. So those clinical skills videos are really helpful. A lot of musculoskeletal on there, a head to toe is on there. I'm really proud of the work that we've put together to really help you enter your clinical rotation and clinical practice. And so the Sure Pass versus the Sure Pass Pro just also bundles in that mentoring session as well. But if you feel like what we talked about with those parts of the EKG, okay, you got that. But as we're talking about the rest of the lecture, you feel a little bit lost. Don't worry, these lectures are all recorded. You can go back and watch them again. You can watch previous lectures, and then you can dive into a little bit more material. You're not on your own. You can always email us if you just don't know where to start, and we're happy to help you. So I just wanted to do a little brain pause and say it's all doable, and it's okay if it feels a little bit overwhelming. Just try to watch today's lecture and take a few nuggets away from it and then go back and study a little bit more. And I'll give you guys some study tools as well at the end of this webinar. I have a great book resource, and then I also have a great EKG simulator that I use and recommend a lot for practicing those abnormal EKGs. Okay, so jumping into interpreting these EKGs, we talked about the basic parts of an EKG. Now let's talk about how to look at the whole 12 lead together, right? The way I like to approach it is systematically. What that does is gives you the confidence to know that you've checked for everything, right? If you're doing it the same way each time, then you know that you haven't missed anything. And it gives you a little bit more confidence as you're interpreting these 12 leads. So this is my systematic approach. You can come up with your own. I'm going to walk you through how I like to do it. And really, as you're studying, you might make a couple little tweaks and come up with your own, but do it the same way each time, especially when you're practicing, because then you'll feel a lot more confident of, okay, I checked for this, I checked for that. The way I usually do it is I like to scan the 12 lead and see if there are any general impressions that pop out at me. Then I calculate the rate and the rhythm. I look at the QRS axis, and we'll talk about that. This is something that really baffled me when I first entered clinical practice on a 12 lead. But once you learn it, it really makes a lot of sense. You're not going to be tested that advanced on your boards, most likely. They're going to give you very basic abnormal arrhythmias, but this is just going to be useful for your clinical practice. We're also going to talk about hypertrophy and how you may see that on the 12 lead. And then we're going to talk about the big ones that you don't want to miss, which are the ischemia and the infarct. But that's the way I approach my 12 leads. And that's how we're going to talk about it today as we're going through. So let's look at a normal sinus rhythm. Remember, each of those little boxes are telling us something. You always want to look at a 6-second strip. So remember what we talked about, those tiny little boxes are 0.04 seconds. You count them out, there are 5 there, so this is about 1 second. You count out this 1, 2, 3, 4, 5, this is 5 seconds, and then you count all of them, so 5, 10, 15, 20, 30, 40, wait, did I miss? How did I not count this right? Okay, so each of them, if you count it out, this is about a 6-second strip. So you have those 0.04s, you calculate, that's 0.2 seconds, you calculate that, that's 1 second. So here you have 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. So you have a 6-second strip. I messed up on the math. I'm sorry, you guys, not enough coffee or maybe too much coffee today. So you always want to look at a 6-second strip when you're going through these strips. Even on a 12 lead, which is really, it gives you those continuous strips. You want to break it down into those 6 seconds. So then we're going to look for general impressions. Is anything popping out at us? No. Let's look at the parts, right? Is there a P wave for every QRS and T? And you're going to look at each complex. So you're not just going to look at one and say, okay, there's a P wave for QRS and T. And you'll see the reason for that as we're talking about other arrhythmias, but you're going to check every single complex within the 6 seconds. So P, QRS, T, P, QRS, T, and you're going to go all the way through and see that, yes, there's a P wave for every QRS and there is a T wave in every single one in the 6 seconds. Then we're going to check our interval. So you're going to look at that PR interval and count and see, is this within that 3 to 5 boxes? And again, you're going to do this each time because there are arrhythmias we'll talk about where this PR interval may change, and that will be indicative of what this arrhythmia could be. So here we're seeing every single PR interval is normal. Then we look at that QRS complex. Is it narrow or is it wide? And we'll talk about the importance of that. But a narrow QRS is less than 3 boxes, less than 0.12. And you're going to look at each one. They're all narrow in this normal sinus rhythm, right? And now, lastly, we're going to check the rate. So we're going to be talking about a normal rate for an adult between 60 to 100 beats per minute. And how do you check for rate? You can do this in a lot of different ways. The way I like to do it is to check that R to R. What that means is you're not just counting the R waves, right? You're not counting 1, 2, 3. You're counting the R to R. And so when we count the R to R, we get 1, 2, 3, 4, 5, 6, 7, 8, and you're going to multiply that by 10. So the rate here is 80. Now, if we had counted each R wave, we would have gotten 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. And we would have incorrectly calculated this rate as 90. So you really want to count that R to R. And so this is a normal sinus rhythm because the P waves are present for every QRS. The PR interval is normal, that QRS interval is normal, the rate is normal, and we're not seeing anything funky with that T wave. So no T wave inversions, no ST elevation or depression. We're also looking at that QT interval, and that's within normal limits. So really, this is a normal sinus rhythm. All right, let's see if there's anything else I wanted to point out on the slide. Looking at my notes. Nope, that's it. Let's go on to QRS axis. All right, so that QRS axis, like I said, this was the most intimidating thing for me when I was looking at a 12 lead because there's so much going on. And I was thinking, well, I know the normal rhythms. What are these limb leads doing, right? And so what the limb leads are basically doing is it's showing us the direction of that electrical conduction, right? Of that, how the electrical conduction is moving in the heart. And that's all the QRS axis is measuring. And so remember, the heart is slightly, that apex is slightly pointed down and to the left. So normal QRS axis is going to fall slightly to the left. I'm talking too fast. Okay, so it's going to go slightly to the left. So you have your limb leads. And so those limb leads show you the direction. So if you have the conduction, if you have an upward deflection in that one limb lead, and then you have also an upward deflection in that 2, and then you have an upward deflection in that AVF, you see that it's going towards that normal axis, right? But if you have upward deflections maybe towards the AVR, or if you have downward deflections in any of these, meaning it's pointing the other way, then we worry about that axis going in the wrong direction. First thing you should do is really check those leads to make sure they're in the right placement, but it really helps us indicate where that electrical conduction system is moving or what direction it's moving in. Other things to note about QRS axis, hypertrophy. So remember, hypertrophy is when that cardiac muscle, if it's being overused, just like when you work out, right? Those muscles get really thick and beefy. The heart, the remodeling happens in the same way. So if we have a patient who's really struggling with hypertension, their heart is working harder to get that cardiac output out, we're going to get some left ventricular hypertrophy. So those cardiac muscles are going to get a little bit thicker. And so what happens with the electrical conduction there is it's going to take longer for it to travel through those cardiac muscles. So when we have hypertrophy, we might get some left axis deviation because it's going to be traveling a lot slower through those cardiac muscles that have thickened. Now, the opposite is true with an infarction or an MI. Remember, an infarction is dead tissue, dead cardiac tissue. So when the tissue is dead, it's not going to be positively charged when that electrical conduction comes through. So what's going to end up happening is it's going to actually move away from that dead tissue. So when you have like a right axis deviation, because that left side of the muscle, that left side of the heart is usually the area where we see a lot of tissue damage due to prior MIs, we're going to see more of a right axis deviation because that electrical conduction is going to move away from that dead cardiac tissue. So again, that QRS axis really does give us an indication of what's happening with the cardiac tissue and how is that how is that conduction moving through the heart. So again, those limb leads, lead 1, if it's positive moving towards lead 1, it's going to go this way. If it's negative, it's going to go this way. With the lead 2 and 3, same thing. If it's positive, it's going to move this way. If it's negative, it's going to be moving up. And same with that AVR, AVF, and AVL. Remember, AVR is that electrical activity on that right upper side of the heart. That AVL is going to be that left upper side of the heart, and that AVF is really going to be looking at the bottom or inferior wall of the heart. This does get a little bit more complicated as you're looking at it, but I promise you, as you're practicing those 12 leads, when you keep in mind the positive charges and the negative charges and the direction that it's moving in, it'll make a lot more sense. All right, now with hypertrophy, so we can have both atrial enlargement and ventricular enlargement or ventricular hypertrophy. I'm not going to get into the specifics of how to interpret it, but we're going to think about what we're looking at, right? With atrial enlargement, remember that's your P wave. So when you see some funky shaped P waves, I want you to be thinking about the atrium. Is there something going on with the atria? With atrial hypertrophy, a lot of times we'll see a diphasic P wave. And diphasic means you get both a positive and negative charge on that P wave. So you get almost like an S shape on it. And then with ventricular hypertrophy, you're going to see more of that voltage on that R wave. So you're going to see a deeper R wave. Left ventricular hypertrophy is the most common. And there are different criteria you can use to really measure that voltage. And usually it's the sum of the R wave and the S wave in specific leads. There's the Sokolow-Lyon criteria. And so you can get into the specifics of all of that, but really just note that there is both atrial enlargement and ventricular enlargement. And you're going to see that atrial enlargement on your P wave. You're going to see that ventricular enlargement on your QRS complex. Because remember, we're looking at those parts of that EKG and what they indicate. Now, the big ones you don't want to miss, and these ones you should be checking for really every time, making sure it's part of your systematic approach to evaluating these 12 leads, are the ischemia and the infarct. We call that recognizing the 3I triad. So ischemia, injury, and infarct. Remember, with ischemia, that's that reduced blood flow to that cardiac tissue. Infarct, there's already been complete occlusion and those cells have died. So that is what we're trying to prevent, right? So that's really important. I'm going to launch our poll 8 and see if you guys know, what is the goal door to balloon time for an ST elevated MI? What do you guys think? If you see this on an EKG, you see an ST elevation, what is that door to balloon time? Remember, that's the time from the patient's arrival to any kind of medical facility or the emergency department to really getting that occlusion ballooned so that there's reperfusion to that cardiac muscle. What do you guys think is the door to balloon time? Yeah, I see some 60 minutes, some 90 minutes. 60 minutes would be great. I see some 90 minutes. I see 45 minutes. Yeah. And so for those of you who have a little bit of a cardiac background, I'm probably really in tune with this because the hospitals are big on measuring this and making sure if somebody shows up to the ER or if they come in via ambulance, we really get them into the cath lab right away to reperfuse that cardiac tissue. But the American College of Cardiology and the AHA, the American Heart Association, their guidelines recommend that first medical contact device time goal of less than 120 minutes, which kind of blows my mind because really the more common goal in the hospital setting is less than 90 minutes. Absolutely. The faster, the better is going to be really important. And so if you're in an outpatient clinic and you're really seeing some ST elevation, that's indicating maybe some acute or recent infarct or injury. That is, you need to make sure that you're getting that patient to the hospital right away because time is of the essence to make sure that we're reperfusing that cardiac tissue. When you see the ST depression, that's already indicative of an infarct. And then we're also looking at that T wave. So T wave inversion really tells us there's some ischemia or reduced blood flow to the heart. I'll give you guys an example. So I had a patient, young 30-year-old patient, came into my office, pretty much doing fine. He just said, at that time I was practicing in an area where it was a city and a lot of hills. And he said, I just noticed that I'm having to breathe a little bit harder when I walk uphill. And it wasn't anything really dramatic, but it was notable. And so he had already seen another provider and gotten dismissed. And he was a little upset about it. He was saying, I feel a difference. I know there's a difference in my body. Now, anytime a patient tells me that they feel a difference, they know there's a difference in their body, my antennas go right up. And I make sure that I'm listening to this patient because people, your body the best, right? As a clinician, we are rushed throughout the day. We may not see some subtle signs, but a patient who's living in their body every day comes in and tells us that something is wrong. We need to really pay attention to that and investigate that, right? So, of course, I ask more questions, and turns out this patient did fly across the country and had surgery done in another state. He had a gastric sleeve done and flew all the way back again. So, red flags right there, recent surgery, long flight, right? And so he had definitely some red flags and maybe some mild symptoms. So I went ahead and listened to him. His physical exam sounded good, nothing notable. I got an EKG on him, and all I saw was that inverted T wave. And so I sent him over suspecting that this could be something to do with his risk factors. So I sent him over to get lower leg Dopplers and a helical CT, because I did suspect that maybe it's a PE causing that shortness of breath or that increased need for respiration. And sure enough, he had multiple DVTs and a large central PE. And this was a very young patient. His body was compensating very well. And if you don't ask the questions, the signs and symptoms may not always be obvious. So you really have to go through that Wells criteria, put in your Wells score when you're evaluating patients. Make sure you're getting them evaluated right away if you even suspect. If you cannot exclude that diagnosis, you need to work it up, especially when it comes to cardiac. So with that T-wave inversion, it can be subtle. It was so subtle on his EKG. I made sure I checked lead placement, and I was like, nope, there's a definite T-wave inversion, but it's indicative of that ischemia, right? Oftentimes we get told about that ST elevation and that ST depression. Those are the obvious ones, but really I want you to be paying attention to that T-wave all around. And then the Q wave, another thing I'll say about a Q wave, so normal Q waves are really small and brief. There are different calculations you can use to look for wide and deep Q waves, which are more significant and more indicative of a potential MI. But again, a Q wave is really that first negative deflection, and it represents that initial depolarization of that ventricle. So it really should be small and brief. So if you're seeing wide or deep Q waves, even if you don't know how to calculate, that should also be a little red flag to you. Wide and deep Q waves could be indicative of an infarct. So really looking at all parts of that QRS complex when we're looking for those 3I triads. All right, so let's get into our arrhythmias. Let me make sure I'm checking my chat. You guys are doing well. I'm almost done with my 1,600 questions. And you want the on-demand lectures. That's great, Patricia. So you can definitely, in your student dashboard, you can add those on-demand lectures. If it gives you any problems, you can always email us and we'll get IT to help you out. But I'm so glad that you're going through our QBank, and really there are 1,600 questions and you can filter them with unused versus used and get new batches every time. So I'm glad you're finding those useful, and the on-demand videos you can always add on to your package as a little combination package, or you can upgrade to the SurePass, which also throws in our live review. Thank you, Patricia. Let's see if I have any other questions in the chat before we move on to the arrhythmias. You guys look like you're doing great. Lots of participation from all the different channels. Awesome job, you guys. All right, moving on, jumping into arrhythmias. All right, so first one, this one is a pretty easy one, but I also want to talk about it because it's not one that we should ignore, right? So sinus bradycardia. How is sinus bradycardia defined? It's a resting heart rate of less than 60 beats per minute in an adult. So let's talk about this. So we get a normal strip. Say it didn't say sinus bradycardia. How do you know this is sinus bradycardia? Now, we're looking at the general impressions. We're going to look for all our parts. Is there a P for every QRS, every T wave? We're going to look at all these complexes within the 6-second strip. So there is a P for every QRS. There's a T wave, P, QRS, T wave. We see that. Now we're going to check those PR intervals. PR interval is normal. It's within 0.12 to 0.2, and it's that way throughout. So our PR interval is normal. Now we're going to look at our QRS complex. So it's narrow, less than 3 boxes, less than 0.12, and it's narrow all the way through. We're not seeing any PVCs, which we'll talk about. Now we're going to check that rate. So the rate, again, the way I like to do it is to go from the R to R and then multiply it by 10. So you're going to go 1, 2, 3, 4. Maybe we'll give it 4.5. You'll get a little comfortable with that as you're looking at that. So this rate is about 45, which is less than that normal 60 to 100 in an adult. So this is pretty classic sinus bradycardia. Now, with sinus bradycardia, it can be normal. It can be normal in our really young, healthy, athletic patients. However, we should always investigate the cause of the sinus bradycardia, right? So this may not always need intervention, but the main thing is we do need to have cardiology evaluate this patient and see what is the underlying cause for this sinus bradycardia. Oftentimes with my older patients, their baseline will just be sinus bradycardia, and I will see, and I always compare my 12 leads to previous 12 leads, and I'll note that in the record when I'm interpreting it. I'll write it by hand and then sign it on that 12 lead and scan it back into their chart. And I'll always note, I always compare to a prior 12 lead because you want to see if there have been any changes, right? And so I'll get my older patients who are on beta blockers and they're just cruising in sinus bradycardia. That's their normal baseline, and that's okay. They're not symptomatic. Some patients may be a little symptomatic, maybe can't tolerate those beta blockers. Again, we need to talk to cardiology about that. But the point is, sinus bradycardia, it may not always need fixing, but it does need to be investigated. This is not something we should ignore, especially if you're the first one catching it on a 12 lead, if you're getting a baseline 12 lead and a well exam. And I like to do that with my patients starting 40 years and over, just so I can have that for comparison. It really depends on your patient population, what insurance will cover. But it's always nice to have a prior 12 lead to compare to. And if you're picking up on it for the first time, you do need to send them over to cardiology and evaluate it. But again, may not always need fixing. Now let's talk about sinus tachycardia. So the other end of the spectrum, right? How do we know this is sinus tachycardia? So again, let's look at it for the general impressions. The QRS is looking narrow. I see some P waves, some T waves. Let's break it down to each complex. So there is a P for every QRS T wave, P for every QRS T wave, and it's that all the way through. You're seeing that? Good. And so now we're going to check that PR interval. And so you're going to check it all the way through. That PR interval is within that 3 to 5 boxes. Again, all the way through. And then you're going to check that QRS complex. It's narrow all the way through, less than 3 boxes. And then we're going to check that rate. So you're going to go to that R to R, and you're going to count it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 times 10 is 130. So this is sinus tachycardia. The rate is over 100 beats per minute in an adult. It's less than 150 beats per minute. That's really important. We'll talk about SVT in a minute. And so this is pretty classic sinus tachycardia. There are different causes. Drugs can certainly cause sinus tachycardia. I had a patient who was being overtreated on her thyroid medication. She was taking too much levothyroxine. She had lost weight. Remember that medication is weight dependent. She lost a lot of weight on her GLP-1 intentionally. And so now she was being overtreated with her levothyroxine. And she noticed it on her Apple Watch. She's like, you know what? I'm just at baseline. My heart rate is up. And we sure enough evaluated it. We fixed the underlying issue. We brought down her dose of levothyroxine, and she then went back into normal sinus rhythm. So oftentimes drugs can cause sinus tachycardia. Exercise, fever. So patients coming in sick, they might come in with sinus tachycardia. Patients who are uncontrolled diabetics, I have a lot of those patients come in with sinus tachycardia. But the key with sinus tachycardia is that it is gradual. And we'll talk about that with our next poll. So what if I said this patient had sinus tachycardia and they were also hypotensive? Well, I'm mixing up all my polls. I try to put in all these fun polls for you guys, so I'm not just lecturing. But let's go through this poll. How do we know this is sinus tachycardia and not a ventricular tachycardia? That's a good question. How do we know? What are we looking at in our parts of the EKG? What do you guys think? no right or wrong. Well, there are right or wrong answers, but remember, participation is anonymous. So how do we know this is a sinus tachycardia and not a ventricular tachycardia? Remember, yes, I love that. So think about your parts of the EKG. Sinus tachycardia. So these sinus arrhythmias, we're looking really at prior to the QRS, right? So if you see that QRS is normal, you know this is a supraventricular tachycardia, meaning it's above the ventricles. If that QRS is wide, then it's a ventricular tachycardia. So absolutely. So the QRS is normal. That's how we know it's a sinus tachycardia. Very good. So what if the patient had sinus tachycardia and also hypotensive? They came in and they're kind of a little out of it. Maybe a family member brought them in. They're not feeling so great and their blood pressure is low, but their heart rate is up. What would we be concerned about? Yeah, absolutely. Yes, shock, sepsis, we definitely would be worried about that. Awesome job. So now, what if the heart rate, so say the heart rate was over 150 beats per minute, what would we be thinking about? Is this sinus tachycardia or is this something else? What do you guys think? Absolutely. So SVT, absolutely, supraventricular tachycardia. So let's talk about the difference. Let's go back to our other slide here. So again, sinus tachycardia is usually gradual, and there is something that we can fix an underlying issue to get that patient back into normal sinus rhythm. So technically, all these different causes, we really have to investigate what's causing that sinus tachycardia. But the signal's still coming from the SA node. We still have a P wave, so we can see that the rate is just a little bit faster, right? So we just have to figure out what's the underlying issue. Now, supraventricular tachycardia, or SVT, that is typically more of a sudden onset, right? And so let's look at SVT. You see that the P wave is kind of hidden. So this is actually their T wave. You can't see a P wave. And when you count the rate out, it's going to be over 150 beats per minute. You still have that narrow QRS complex. So you know, again, it's above the ventricles. That's a supraventricular tachycardia. But the rate is really much higher than 150. And typically this patient's not feeling so great either. They're not doing so well. They feel not so great. And so this is an SVT. And typically, what is something we can try with SVT? Let me see if I can put that in here. Tachyarrhythmias, but what's a maneuver we can try with SVT to try to get them out of SVT? What do you guys think? I see some thinking, I see some typing. And I think I know what you mean by that. Yes, yes, the Valsalva maneuver. And why is that? So Valsalva maneuver is really that bearing down. And the reason for that is because SVT is really, it's a premature beat that gets caught in a loop. And sometimes when you break that cycle with like that bearing down, it can really snap that patient back into a normal sinus rhythm. Awesome job. So that's the difference between sinus tachycardia and SVT. We really worry about SVT because maybe there's an abnormality, something hidden in that P wave that we can't see, and it's more of a sudden onset. All right, so now jumping into the most common cardiac arrhythmia that you will see in an outpatient practice is atrial fibrillation. And so with this, really the risk increases as our patients age. And we also can see it in post-cardiac patients as well. That's why they keep them in the ICU and watch for any arrhythmias. But atrial fibrillation is really one of the most common things you'll see in an outpatient practice. You might be the one who catches it initially. You might just have patients that come in and that's what their EKG looks like. They're continually, persistently in atrial fibrillation. You also have some patients where we call they're in paroxysmal atrial fib, meaning that they go in and out of atrial fibrillation. But the biggest thing is really our patients, what do we want to make sure we are doing in our patients with atrial fibrillation? I'll launch our next poll. But all patients with atrial fibrillation need to be on what? And we'll talk about why in just a second. But what do we need to make sure all our patients on that have atrial fibrillation are on? Absolutely. What else? So I see a lot of anticoagulation. What else? What else are we worried about with atrial fibrillation? We're going to anticoagulate them because of that stasis of the blood. So good. You guys got the anticoagulation. What else do we need to do with our patients with atrial fibrillation? So we need to rate control them, and what else? Oh, I'm sorry. I just gave you the answer. Yeah, we need to anticoagulate them and rate control them with beta blockers. Awesome job, you guys. Yeah. And I see a lot of typing, a lot of thinking. Absolutely. And let's talk about why. So atrial fibrillation, what's happening in atrial fibrillation? Why are we seeing these little fibrillated lines where the P wave should be a nice arch? What's happening in atrial fibrillation is you're getting multiple foci in that atria signaling. So remember that SA node is supposed to be our initial pacemaker. In atrial fibrillation, you're getting a bunch of different pacemakers in that atria, and there can be a lot of different causes. Oftentimes we'll see atrial fibrillation in the atria that's a little bit more loose and has lost its elasticity. But what's happening is you're getting multiple signals from the atria, and that AV node does do a good job with resetting us, but you get this fibrillated P wave as opposed to one foci, right? Sending that signal, that electrical conduction system. So you get this fibrillated lines where that P wave should be. And what we worry about with that, if you're getting multiple ectopic foci in that atria, that blood is really like the stasis, right? It's just kind of pooling and not really pumping out appropriately. It's kind of like, oh, should I pump out? Should I not pump out? So with that atrial depolarization, it's really not smooth. So that blood kind of gets caught in there. And what ends up happening is it can form a clot, and then you can throw that clot. So that's why we anticoagulate these patients to really help reduce their clotting risk. Now, why do we rate control them? Because again, yes, we have that backup pacemaker with the AV node, but what ends up happening if that AV node could potentially fail, then we can get into a dangerous arrhythmia. So we really want to make sure we're also rate controlling these patients. So biggest key takeaways with atrial fibrillation, you don't see that smooth P wave for every QRS when you're looking at it. You still see a narrow QRS, so this is still a supraventricular arrhythmia. It's above the ventricles. And you still have a normal rate. So if you count it out, it's still a normal rate, but you see that fibrillated line, and we really worry about the stasis of the blood in the atria, and we worry about the rate. So we want to make sure we're anticoagulating these patients and they're rate controlled. Now, if you have a patient who has paroxysmal AFib or known persistent AFib, when you're looking at that EKG, always write by hand that this patient is anticoagulated and rate controlled and sign it. And you want to make sure you're checking that as well. Like I said, I like to print all mine out, write down my own interpretation. I can scratch out whatever the computer overinterpreted or missed, and then I can sign it with the date. And I like to also compare it to my prior 12 leads as well. So atrial fibrillation. What else do I want to tell you guys about atrial fibrillation? So we always want to refer this patient over to cardiology to find out the cause of the atrial fibrillation. And then they can really talk to the patient about the different interventions. Are they going to try to cardiovert them? Maybe they'll ablate them. Remember, these are not foolproof methods. So patients, the ablation may work, but then the atrial fibrillation may come back. So you definitely want cardiology to weigh in on what's going on with their atrial fibrillation, what's causing it, and what the appropriate intervention is. But our job in primary care is to make sure we get them on anticoagulations and get them rate controlled as they're waiting to see cardiology. Now, what is the difference between atrial fibrillation and atrial flutter? Let's go to that poll. But what is the difference between AFib and aflutter? What do you guys think? And that's okay if you guys don't know. I see no typing at all. Oh no. What do you guys think? What's happening in that atria? I see the word tooth. I think you mean that sawtooth appearance of the P wave. That's good. Yeah. Quivering versus sawtooth. Good. The P wave appearance. Yeah, and let's talk about that. Controlled beats, just abnormal. Oh, I like that. That's really great. So yeah, that's exactly how I think about atrial flutter. So the difference between atrial fibrillation and atrial flutter. Atrial fibrillation, you're getting multiple ectopic foci firing in that atria. With atrial flutter, you really have one pacemaker that's firing, but it's firing too fast. So you get that P wave, but you get multiple P waves before that QRS has a chance to contract, right? That ventricle has a chance to contract. So that's why you get the sawtooth appearance of that P wave. Awesome job. So it's more controlled. I like that. That's a really nice way to look at it. So that's absolutely why you see this kind of sawtooth appearance with atrial flutter. Remember that QRS is still narrow, but you have multiple P waves, and then the rate is still normal as well. And sometimes, again, depending on what that atrial flutter, what's causing it, it'll also determine the intervention that cardiology is going to recommend. But absolutely atrial flutter, we want to get that patient over to cardiology. And this patient, I would probably rate control while they're waiting to go see cardiology. And then you always want to ask, is this patient symptomatic? Do I need to pick up the phone and have that warm handoff where they're getting into cardiology right away? You don't want them sitting in that referral bank. So are they symptomatic or are they not symptomatic? So it can really range. All right, so let's practice a couple of practice questions from our Q bank, and I'm going to launch the poll in case you guys read a lot faster than I do. And so here we have a 51-year-old patient who's taking warfarin. Also, they'll give you Coumadin or warfarin. They'll give you both the generic and brand for atrial fibrillation, and the INR, the international normalized ratio, that INR this morning is 2.5. Which of the following is appropriate? A, the warfarin should be discontinued and an antidote given as the INR indicates toxicity? Is it B, the dose of warfarin should be increased as INR is too low for therapeutic range? C, dose of warfarin should be decreased as the INR is too high for the therapeutic range? Or D, that dose of warfarin should be maintained as the INR is in therapeutic range? So like I said, for the boards, you're going to get pretty straightforward questions like this most likely. It's not going to be as complex as what we've been talking about today, but it's good to know for clinical practice as we're really talking about these real case scenarios. So what do you guys think with this patient who is on warfarin, being anticoagulated, getting their INR checked? What is that normal therapeutic range that we should be aiming for? So I see some answers. Some people think the dose should be decreased. It's too high for that therapeutic range. Dose should be maintained. It's within therapeutic range. I see some people going back and forth about that. And you might get some patients who are they're managed by cardiology, but you guys share the same EMR system, and that patient's there to see you for something else, and they say, hey, can you look up my labs and interpret this? So you might not be the clinician who's ordering the INR or managing their INR, but this is definitely within our wheelhouse and something that we should be comfortable with. So that's why you might see a question like this pop up on your boards exams. And so I see about 63% of you, majority, say the dose of warfarin should be maintained as the INR is in therapeutic range, and that's absolutely true. So D is the right answer. So if you take it on our Q bank, it gives you the rationale, but really therapeutic range is an INR between 2 to 3. So you would not touch this patient's warfarin or Coumadin, and you would just reassure them that they are within therapeutic range. Awesome job. Okay, so now talking about our ventricular arrhythmias. I remember when I was in school, everybody would say like, oh, when you think ventricular arrhythmias, it's dangerous, ventricular arrhythmias. I like to start with a ventricular arrhythmia that's not so dangerous. This is probably one of my most favorite ventricular arrhythmias, a premature ventricular contraction. We'll talk a little bit about this. But in general, yes, if you see a ventricular arrhythmia, we'll talk about why it's the most dangerous, or we should be thinking danger when we see a ventricular arrhythmia. But let's actually think about what we're seeing, right? So a premature ventricular contraction is when you get a premature contraction of those ventricles pop in, so it bypasses that AV node and it just gets stimulated and it contracts. So you see this wide and bizarre looking QRS, and then otherwise it's normal, right? And typically you'll see this in patients. Sometimes you might find it incidentally. You're doing a 12 lead for another reason, and you might find one PVC. You might find it in patients if you're running that EKG because they say, you know, every once in a while I feel like a little sudden, like I lose my breath kind of quickly, and then it goes away on its own. You're asking more questions, no other cardiopulmonary symptoms, and it happens very infrequently, very rarely. And so you get a 12 lead and you might see a normal sinus rhythm, or you might catch a PVC, a premature ventricular contraction. And so that is really something to think about. If your patient is symptomatic and you do see a PVC, a premature ventricular contraction, what should you do next? What are you going to order? Is this something where you're like, okay, this is pretty common in most patients, or are you going to order another diagnostic test? What do you guys think? What would you think I would order in that scenario if the patient's saying, every once in a while I feel a little flutter, and you may or may not see that PVC on their EKG? What would you order in that case scenario? Or maybe not. You wouldn't order anything else other than that EKG. I see some people typing. Two people typing. A Holter monitor, some labs, just an EKG. So we're kind of all over the map. I love that. Okay. So let's talk about this. So a premature ventricular contraction, yes, you can get that ventricle kind of firing off, and it's normal in the majority of the population. But if I have a patient who's telling me they're symptomatic, I'm probably going to order an event monitor or maybe even a Holter monitor to try to capture that when they're not in the clinic. Because remember, a 12 lead EKG is just a very small window of what's happening with that patient's electrical conduction system, right? It's just what's happening on that table. So you may have a patient who has normal sinus rhythm, but if it's something that's happening pretty frequently, I would probably order an event monitor, which tracks when the patient's having an event, having those symptoms. They can track it on their monitor, and it can evaluate it to see if they're getting a run of PVCs. And so a run of PVCs is a run of 3 or more premature ventricular contractions in a row, because then I would be concerned about a really dangerous ventricular arrhythmia, like ventricular tachycardia presenting, right? So absolutely, premature ventricular contractions are fairly benign, are fairly common. You may find them incidentally. You may have a patient who just experiences them outside of the clinic. But if you have a patient who is symptomatic, always follow up with that event monitor or even a Holter monitor that they could wear for 3 days to see if you can capture that depending on the patient's history. So you're going to ask them, how often do they feel it? They might say, I feel it once a week. Then you might want to get that event monitor and have them wear it at least for a week to see if you can capture it and make sure you rule out that run of PVCs. Awesome job. So now getting into our dangerous ventricular arrhythmias, ventricular tachycardia. Remember, we've been talking a lot about the parts of the EKG. And so the biggest difference you'll see here is this QRS complex is really wide and bizarre, right? That's what makes it a ventricular arrhythmia. That's what made that premature ventricular contraction a ventricular arrhythmia. It's wide and bizarre QRS. And with ventricular tachycardia, that's all we're seeing, right? And what makes this really dangerous is that poor cardiac output. So if you're picturing what's happening with the ventricles, they are just contracting very fast, right? So that ventricular rate is very high. You're seeing these wide, bizarre QRS complexes. The P wave, there is no signal coming from that SA node anymore, right? The ventricles have taken over, and they're kind of in this desperate mode of really trying to get that cardiac output up, right? And so oftentimes we'll see this in patients who may be experiencing an acute cardiac event, maybe hypoxic, hypokalemic, hypotensive. So this is a dangerous arrhythmia that we want to intervene right away. If that patient still has a pulse, we're going to cardiovert them. If they don't have a pulse, then we are going to instigate that ACLS protocol. But things like drugs, electrolyte abnormalities, structural heart disease, MI, left ventricular dysfunction, all of that can cause this ventricular tachycardia where the heart is just desperate to get that cardiac output out. And so that can progress really into ventricular fibrillation. So the difference between that VTAC and VFib, you see here that those ventricles really are not getting much output out. Now they're kind of just spasming, there's some fibrillation, but they really are not able to get that cardiac output out. And that's what we worry about. VFib is a type of cardiac arrest. And so those ventricles really are not able to get the blood out of the heart into the rest of the body. And I think I have a poll here for you guys. Did my poll disappear? Let's see if I have it. I think my poll disappeared, but basically take home message is with VTAC and VFib, we really worry about that cardiac output. And that's why we need to intervene right away and initiate ACLS protocol. All right. Now let's get into our bundle branch blocks. I'm aware of the time. I get a little chatty with EKGs. So I appreciate those who are still on and chatting and participating with me. I'm glad we gave ourselves an hour and a half as opposed to just the hour. All right, so let's talk about our bundle branch blocks. Remember, with the SA node, with the electrical conduction system, it's starting in that SA node, goes to that AV node then goes down that bundle of His and breaks off into that right and left ventricle. What's happening with a bundle branch block is that there's really a delay in that impulse on either the left or that right bundle branch. So instead of the ventricles contracting continuously together, you're going to get this like do-dum, do-dum. And so you're going to get a little bit delay in one of those ventricles contracting. And so that's what you're seeing. That's why you're seeing 2 R waves on your EKG. And so remember, we have our limb leads, which we talked about, and then we also have our chest leads. And our chest leads are those V1 through V6. The beginning chest leads, so like V1 through V3 are really looking at the right side of the heart. V4 through V6 are looking at that left side. So I always like to look at my leads, think about where we're looking at in that heart. Again, why placement is really important. And then if I'm seeing that M wave in my left chest leads, I know it's a left bundle branch block. If I'm seeing that M wave in my right chest leads, I know it's a right bundle branch block. Either way, with these bundle branch blocks, some people can have known bundle branch blocks. They're followed by cardiology. Some people, you may be the one who captures it first. Either way, this does need to go to cardiology and be evaluated and figure out what's going on. Has there been some underlying damage to that cardiac tissue? Has there been some remodeling? Why are we getting a delay? Why are those ventricles not simultaneously contracting, right? That's really important. So left and right bundle branch blocks. Last thing I'll say is left bundle branch blocks are going to be more common because oftentimes we'll see a lot more changes to that left side of the heart. Right bundle branch blocks just bother me. They worry me a little bit more because oftentimes it's not as common to get injury to that right side. So if I see a right bundle branch block, I get a little bit more worried. Now let's talk about our heart blocks, and that's our last section, I promise, and then we'll get into our case study. And so first we're going to start with this 1st degree heart block. Now, what makes this a 1st degree heart block? Again, let's look at the 6-second strip. We're going to look, general impressions, everything looks fine. Maybe you're more astute than that, but you might look at it and say, it looks fine. You're looking for a P for every QRS and the T wave. You're going to look at all those complexes all the way through, and there's a P wave for every QRS and a T wave all the way through. Then we're going to look at our interval. So our PR interval, you're measuring it and you're like, wait a minute, that's more than 5 boxes. So the PR interval is prolonged. And you're looking at every PR interval within the 6 seconds, and you're noticing that it's pretty consistently prolonged. And what I like to do, I take a little sticky note and I make little lines at my P wave, and from P wave to P wave, I march it out to see if there's any difference, right? I like to do that to make sure if it's not, and we'll talk about the next degree heart blocks, but if it's not like prolonged and getting longer, if those P waves are kind of marching out. And then I also like to do that with my R waves, march those out as well. So we see that prolonged PR interval, and then we're looking at our QRS. It's narrow, less than 3 boxes. So QRS complex looks good. And we're looking at our T wave, no inversion. I'm not seeing any ST elevation or depression. Now I'm going to calculate my rate, right? So we're going to go R to R. So 1, 2, 3, 4, 5, 6. That's about 60, maybe 65. So the rate's still normal. So really the only thing here is that prolonged PR interval, and that is what's classic of a 1st degree heart block. Now remember, with the 1st degree heart block, there's no drop in that QRS. Everything is still moving along. There's just a delay in that conduction between that P, between the atria and the ventricle. So that's the big tell between this and a different type of heart block, which we'll talk about. This can be normal. So sometimes in our athletes, it can be normal. We may see this in the patients with electrolyte disturbances. That's not normal. Or if they have some congenital heart defects, certain drugs can cause this. In our pediatric population, we want to make sure we're not missing myocarditis, though they're going to be a lot more sick, most likely. But typically, the biggest key thing with first degree heart block is typically it may or may not need a fix, but we do not want to ignore it. So it does need investigation. So it does need to go over to cardiology, and they need to evaluate what's causing the first degree heart block. And then they can tell us that this is, just a really young, healthy, athletic person and they're doing well. But we definitely don't want to miss it in our pediatric patient population, or we don't want to miss it if something else more serious is going on that we need to address. But typically treatment's not really required. This is a pretty benign heart block. And the reason for that is because the rate is preserved. So there's no hemodynamic instability. We still have good cardiac output. That is the most important thing. Remember, that is the whole point of our heart's conduction system, is to initiate the contraction and get that cardiac output out. Now let's talk about second degree heart block type 1. This goes by a lot of different names. Don't get confused. I do have a little poem at the end where you could try to, for test day anxiety, remember it, but it's also called Mobitz 1 or Wenckebach. And so with second degree heart block, let's take a look at the whole thing. So general impressions, what's going on here, right? We see a couple of things missing. Now let's look at our parts. So P, QRS, T wave, P, QRS, T wave, P, QRS, T wave, P. Where did that go? Where did that QRS complex go? Where did that T wave go, right? There's no ventricular contraction or relaxation, no depolarization or repolarization here. Then it picks back up and we're looking at it. Okay, it happens again. And so now we're going to look at our intervals. So you're looking at your PR interval. That one's normal. You look here, wait, now it's getting prolonged, longer than 5 boxes. Here, again, more prolonged. And then here, there's a drop, right? And you're seeing that again. So normal, longer, drop, right? That is pretty classic of the second degree heart block type 1. So you get that prolonged PR interval until it drops. Your QRS complex is still narrow. So you're looking at that for those QRS complexes that are there. They're still narrow. They're less than those 3 boxes. And the rate, let's calculate the rate. So you're getting 1, 2, 3, 4, 5. I'm going to give this a 6. So the rate typically is still normal, and that's why this one's not as dangerous as the second degree heart block type 2, because this patient is still hemodynamically stable. They're still getting enough cardiac output. I do worry about that drop QRS, so absolutely we need to evaluate what's going on. Typically we'll see this post-cardiac surgery. We might also see it in patients with an MI or myocarditis, an infection of the heart, but we really want to investigate what's causing that dropped QRS. Classic way to interpret it is really that prolonged PR interval until you get that dropped QRS. Some patients may be symptomatic, some patients may be asymptomatic. Either way, it needs to be evaluated by cardiology. Now, second degree heart block type 2. This is also known as Mobitz 2. I worry a lot more about this, and we'll talk about this in a second. So we're looking at it, general impressions. Again, kind of looks funky, something's missing. We're going to look at our parts, P, QRS, T wave, P, QRS, T wave, P, dropped. There's no QRS, there's no T wave. Picks back up again and does it again here, dropped QRS, right? Now we're going to look for all our intervals. So PR interval, that's normal. And we look PR interval, normal again. There is no PR interval here because there's no QRS complex, but then when it picks up again, this PR interval is normal when it's not a dropped QRS. So that is a pretty classic sign of second degree heart block. So PR interval is normal, that QRS is still narrow, but you're getting a dropped QRS. So that ventricle is not getting fired up. There's something going on with that conduction getting through to that QRS. There's no ventricular contraction. You're dropping that QRS. If you look at the rate, this is what worries me about second degree type 2 versus type 1. So we're counting the rate because of that dropped QRS. We're going to get a rate less than 60. So 1, 2, 3, 4, maybe 4.5. That's 45, rate of 45, well below that normal for an adult. So the cardiac output is starting to get really compromised there, right? So that this patient is not hemodynamically stable. We absolutely would need to pace this patient and see what's going on so that it does not progress to that third degree heart block. Again, we watch for this. Most likely happens in that post-cardiac surgery, especially with valvular replacements, based on where those valves sit with where that AV node is. So we do watch these patients really closely, make sure they haven't developed some sort of heart block. But you might also see it in your outpatient practice if someone, I mean, I guess I've never seen an outpatient practice, but if someone's experiencing an MI or if they're on cardiac meds that could be causing some electrolyte imbalances, could also happen. And then last but not least, our third degree heart block. This is what we call our complete heart block. This is most serious, of course. And why is it the most serious? So I'm going to launch this next poll. Oh my gosh, where does the time go? Just chit-chatting. I'm so glad you guys are enjoying it and still here. I appreciate that. But does anybody know why Mobitz 2 and third degree heart block are the most serious? And I've mentioned it a couple of times. What is the most important thing with these cardiac arrhythmias? Why do we worry about the heart's conduction system not performing optimally? Yes, that cardiac output. Absolutely. Absolutely. So with Mobitz 2 in this third degree heart block, the biggest thing we're worried about is that cardiac output, right? So if you have severe bradycardia, you're not getting enough blood perfusing the brain, the heart itself, the rest of the body, and it can lead to death or cardiac arrest. Low batteries. I like that. I like looking at it that way. So absolutely with third degree heart block, how do we know this is third degree heart block? Well, aside from the severe bradycardia, which we'll calculate, this is complete failure of that AV nodal system. So when you're looking at it, general impressions, you're like, something's funky here, right? And you're looking at it, you look at the parts, and the P waves are not talking to the QRS complex. So there's not a P for every QRS. But if you march it out, the P's are actually talking to each other. So the P waves are talking to each other. The atria are talking to each other. The R waves are talking to each other, but the atria and the ventricles are not talking to each other. They're just beating to their own drummers, and it's just completely variable. Everything is variable, including that cardiac output. It's less than 60, and that's what we worry about with these patients with third degree heart block. Absolutely, you guys. Awesome job. So here's a little poem. If you like little poems or little memorization tools, I never really gravitated to these things, but I know test anxiety can sometimes feel a little overwhelming. So it's nice to have these in the back of your pocket if it works for you. But remember, if that R is far from P, then you have a first degree. Remember what that first degree was? That was going to be that prolonged PR interval. You still don't have that dropped QRS. So I'm not so worried about a first degree, but you still need to investigate it. But that is that PR interval that's prolonged. Longer and longer drop, then you have a Wenckebach. Remember, Wenckebach is another name for that second degree type 1. And so that's when you're getting that prolonged PR interval until you get that dropped QRS. So starting to worry about this patient a little bit more than my first degree. If some P's don't go through, then you have a Mobitz 2. Remember, Mobitz 2, another name for that second degree type 2. And that's when that PR interval is normal, but you get that drop QRS, and we're worried about the rate. This patient's going to be bradycardic, right? Poor cardiac output. If P's and Q's disagree, then you have that third degree. Again, P's are marching to their own drummer, Q's are marching to their own drummer, but they're not talking to each other. There's not a P for every QRS. It's just not, they're not talking to each other, and that bradycardia, that severe bradycardia, is my biggest concern for this patient going into complete cardiac arrest. So that's your little poem. Let's practice one more time. I'm going to launch this poll for us. One more practice question before we get into our case study. So with that QT prolongation, what does that predispose a patient to? What arrhythmia are we worried about? And some of you said it in the beginning of today's lecture. Some of you, it might be something that you learned in today's lecture. but what are we worried about? And this is something that might pop up, something like this on the boards, because they really want you to be thinking about this, right? They want you to be checking for these things when you're looking at this patient's 12 lead. Safety first, right? So with that prolonged QT, we really worry about torsades. Awesome job, you guys. Torsades is a type of ventricular tachycardia. Awesome job. All right, let's see. And that's the answer you get. So these are my resources that I really recommend. Again, I'm not promoting, I'm not speaking for the people who wrote these books. I'm not speaking about who they are as humans, but in terms of teaching yourself and resources, this is something that was recommended to me when I entered clinical practice by my mentors. And I'm so grateful for it because it really does break down everything we talked about today. It really breaks down the parts of the EKG. It helps you really understand what you're seeing on the graph paper as it correlates to what's happening in the heart. So it's a really nice way to teach yourself and continue to teach yourself how to interpret these 12 leads. There's also this little EKG simulator that I really like to use, and you can pause it, you can learn from it, you can do it in a practice session, you can do it in a quiz session, and it'll give you different EKGs and you can practice interpreting them, and it'll tell you when it's the right answer and when it's the wrong answer. So practice, practice, practice is my biggest tip for you guys. Remember, all these tools are available to you. If anything, start with that free trial. That's always a fun way to dip your toes in and see if you like what we have to offer. Our on-demand videos, over 16 hours of content. You can navigate it really easily. It's nice. So you can go to those sections that you really want. It's labeled into little bite sizes. And then we have those awesome clinical skills videos there. And then the SurePass and the SurePass Pro really bundles all of it because that is our recommendation with that SurePass method. You really want to make sure that you're watching videos and then you're doing about 25 to 50 practice questions. You're going back, you're reading the rationale and doing those readiness assessments tests to know when you're really ready to sit for the boards. And we do have mentoring, so you can always join us in our community. Go to our website and reach out to us one-to-one if you really want somebody to help you create a study plan, or if there's something that you're getting stuck with during your clinical practice. We really are here, seasoned nurse practitioners who've been through it, have done it, and would love to help you through your journey and help you feel more confident as you're going through. And you can always email us directly. That'll come to me. All right, with just a few minutes left, let's go into our case study. So here's our little friend, John. I always like to use John Doe as our case study, 58-year-old male. Height and weight, he's a little bit overweight, he's obese. Medical history, you follow him for his type 2 diabetes, hypertension, hyperlipidemia. He also has a strong family history of cardiac disease, type 2 diabetes, MI. Lifestyle, he's mostly sedentary for his job, but he's trying to be more physically active, but he doesn't eat so well, but he knows that there are some things that we're trying to work on. Now he comes into the office and he says, I've been trying to get on the treadmill and walk a lot more, but I'm noticing that I'm just more tired. And so is this exercise fatigue just because he hasn't been working out, or is this something we need to be thinking about a little bit deeper? I really wanted to go over this case study with you guys because this is a real case that happened early on in my clinical practice and I still remember it. So John comes in and he says, I'm just a little bit more tired. I'm noticing that I have to breathe a little bit harder when I'm on that treadmill. So you might think okay, yeah, you haven't been exercising, you're overweight, you're going to breathe hard. But you want to ask those questions, right? So he doesn't have chest pain, no palpitations. He doesn't feel like he's going to pass out. He's never passed out. He's not short of breath. He just feels like he has to breathe a little bit harder. And then when he's not short of breath, when he's just sitting and talking regularly, or with any other activities, really, he's not noticing it. He does admit, as you're asking more questions, that he does feel some jaw discomfort, but he really can't say if it's happening just when he's on the treadmill or if he just usually has some jaw discomfort. His dentist says he might have some TMJ. I don't know. So not a great historian. You'll see this a lot in clinical practice. You have to really dig a little bit deeper with your patients. That's what this case study is really trying to get across. So current medications, he's on metformin, lisinopril. He's also already on a statin. Vitals look good today. Blood pressure looks great. Pulse looks great. Physical exam, he is overweight. No signs of TMJ that you could pick up on. Heart sounds good, lungs sound good. He's not in any acute distress. You go ahead and you get that EKG because of his risk factors, because you're an astute clinician. He's a normal sinus rhythm, rates normal, no T wave inversions, no ST elevation or depression, no prior EKG to compare it to. So this is also what I write on my 12 leads and then sign my name and put the date on it. So I wanted to put that in there for you guys, just so you can get in the practice of doing that. One of my mentors taught me that, and I think it's a really good way to practice. Lab results. So his A1C, not quite at goal, but not terrible. Lipid, again, not quite at goal, but not terrible. Can see that he's not doing much exercise, diet's not great, and then other labs look good. So what are our initial thoughts? And I'm going to launch our word cloud here, but what are our initial thoughts with our friend John? What do we think is happening with him? Do we think that this is something we should worry about? Do you think that this is just exercise intolerance? What are our initial thoughts? And Larissa, I see your note. I'm going to go over it after this case study. Thank you for that. But we'll talk about that right bundle branch and that left bundle branch in a minute again. Yes. I see some thinking, some writing. Yeah, maybe his lipid panel is not at goal, his A1C is not at goal, exercise not at goal, whether his blood sugar is looking like. What if I told you guys that you're suspecting something's going on with his heart? And so somebody just wrote it, but would you guys stress this patient? I see somebody wrote stress test. So you're thinking, okay, this is exertional dyspnea, right? It's not just exercise intolerance. He's got a lot of risk factors. Would you stress this patient? So I see one yes. What do you guys think? Would you guys order that stress test? I see a couple of no's, a couple of yeses. Some people are thinking about it. Why or why not? I'm going to leave it open text. So why would you stress this patient? Why would you not stress this patient? Oh, I see a lot of typing. I like that. I see somebody wrote, because you need to figure it out with a little emoji of, I don't know, to see if he's symptomatic, to see if you can reproduce those symptoms, right? Is that what you guys are thinking? Yes. And then I see someone say, maybe you need to refer to cardiology first, but you would be thinking maybe some ischemia with that exercise, red flag risk factors. Awesome. Okay. So let's talk about this patient. So this, our friend John. So I would say the reason why I wanted to mention this case is because when you have a patient at this age with these risk factors, please do not stress this patient. Because what can happen when you order that stress test? That patient shows up for the stress test. There's usually a tech. Maybe if they're lucky at that facility, there's a clinician monitoring the stress test. But if that happens, if you're getting that ischemia to that cardiac muscle, which is what you're suspecting, what could potentially happen on the stress test? What do you guys think? What could happen to this patient? Yes. An MI, a myocardial infarct. Absolutely. Oh, it gives me chills just thinking about it. So you do not want to stress this patient. So this, I really wanted to emphasize this because I do see this in clinical practice and I don't want you guys to get into this pickle. So you would not stress this patient. This patient needs to go to cardiology. They have a lot of risk factors and they're now telling you they're symptomatic. Cardiology can do an evaluation that's non-invasive, that's supervised to determine what's causing the symptoms without harming this patient, right? That is the most important because if you were to stress this patient, he could potentially have an MI during that stress test. And in fact, this patient, this is a real life patient, he did in fact have severe coronary artery disease and he required a cabbage. So he went over to cardiology. So this wasn't a patient that I saw. One of my colleagues, a nurse practitioner, saw this patient and did the right thing, sent him over to cardiology as opposed to ordering that stress test. She saved his life because he did have his three main coronary arteries severely occluded. And so he then was scheduled for a cabbage. Absolutely. If she had ordered that stress test, this would have been bad, right? And this guy was lucky because she caught it. She caught it with those subtle symptoms. And in fact, I saw him for follow-up and he came in really mad. He was just so angry. And so oftentimes patients don't understand what we're doing and why we're doing it. And I had to explain to him that it was appropriate for her to send him over to cardiology because in outpatient practice, we're managing these patients with labs, listening to them, EKGs, all that can remain normal for a really long time. But if you have a patient with these risk factors, at this time, we didn't have a calcium score. If you have a patient with these risk factors, you absolutely do not want to hesitate to get them over to cardiology to do a more thorough evaluation, especially if they're coming in with any inkling of symptoms, right? And that jaw pain, that jaw pain was related, but he was a poor historian, right? And my colleague did such a great job picking up on this and sending him over to cardiology. They did a cardiac cath at the time. They did an EKG. They did the carotid Doppler just to make sure there was no occlusion of carotid arteries. But yeah, he was scheduled for a cabbage and he was mad about it, which is so funny because patients really don't understand. So what should we have done? And you guys can put this in the free text. What else should I didn't see this page, but what else should we have done in that clinical visit before sending him over to cardiology? And we said this with what cardiology did. They did a Doppler of his carotids. I'm giving away the answer, but really listening for that carotid bruit as well when you're listening to the heart is going to be really important in this scenario as well. But the biggest takeaway, if you have a patient with risk factors, don't hesitate to send them over for a full evaluation with cardiology. They have a lot of non-invasive ways that they can evaluate those coronary arteries now between the calcium score and doing a CT angiogram of the heart to really light up those coronary arteries to see where the occlusion is. Those are all really non-invasive ways of evaluating it, right? They don't necessarily have to have that cardiac cath until they're going in for surgery. But absolutely do not hesitate to get that full evaluation on your patients. And lastly, do not stress patients where you are suspecting that there could be signs of ischemia, right? You could put them into an MI and they're going to be worse off and it's going to be dangerous for that patient. All right, you guys, that was my case study. Thank you so much. I know we went a little bit over. I always do because I can't help it. I feel like every time I give these lectures, I have a million things I want to tell you guys. Before you hop off, I want to see how confident do you feel now interpreting a 12 lead? And this really helps me gauge and tailor my lectures to you guys to see if I need to add stuff or not add stuff. But from when you started, I know some people were kind of in the not confident at all. Some people are hovering in this middle score, but how confident are you feeling now that you've gone through the lecture? And I see a little bit of improvement. Oh, wow, I see some improvement. That's awesome. And the next Slido, the last Slido I'm going to give you guys is I want to hear what you guys want for future webinars, because this was a webinar that's backed by popular demand. I've done it a couple of times now. Each time it's a little bit different. I add some things, but I want to hear from you guys what you want more of. But it looks like overall you guys are feeling more confident, which makes me feel so happy because I feel like I taught you something today, which was my goal. So that's great. And then, so what content would you like to see in future webinars? We do have a couple people asked for billing and coding, and that's getting on the schedule for April. So our lovely Brittany Long is going to add one of those for April. But what else would you guys like to see in future webinars? More case studies, professional practice. We definitely have a professional practice one coming up too. Case studies we're working into all our lectures, so I'm glad you guys are enjoying that. Gynecologic exams. I love that. We have an awesome GU lecture coming up next week with our wonderful Jennifer Bonner. Don't miss that one. She's going to go into a lot of women's health and OB care. I know you guys have asked for that before, and give us some good feedback from that lecture, what you want to see more of in that lecture. But absolutely, for gynecologic exams, those clinical skills videos on our on-demand video, we also include that gynecologic exam. So check that out. Some more pharmacology, absolutely. We're cranking those out as fast as we can. So get definitely more pharmacology. quick, high yield overall, those are going to be more of our live reviews. So these webinars are really a chance for us to really showcase to you guys the high quality information that we're putting together, especially in our on-demand videos and our Q bank. For that high yield overall quick review, that's going to be more of our live review. And so our next one will likely be at the end of May. We're working on putting that calendar together now, but absolutely, if you guys want those high yield reviews, those are going to be our 3-day lives. So that's great. All right, you guys. Well, thank you again for joining me today. I really enjoyed talking to you. I appreciate all the interaction. I'm so glad you guys have learned something walking out of today's lecture. Larissa, I did not forget about you. So you were asking about those bundle branch blocks. Remember, these webinars are recorded and you can go back and watch them. They get posted on our YouTube channel and Facebook channel. So you can go back if I went too fast over bundle branch blocks. But remember, with that right and left bundle branch, you're going to see a delay in that contraction of one ventricle. So you're going to see 2 R waves, and then you're going to see that M. So remember, the right bundle, the right side of the heart are going to be your V1 through V3 chest leads. The left side is going to be your V4 through V6. So if you're seeing the M on those right chest leads, it's a right bundle branch. If you're seeing that M on the left chest leads, it's going to be a left bundle branch. I hope that answers your question, Larissa. Feel free to email me if you want any more clarification on that. And so Patricia, I can't send you the on-demand videos myself, but if you scan this QR code, it'll take you to our website and you'll be able to upload those or add those on-demand videos to what you're already subscribed for, or you can go into your student dashboard and do that. But great question. Any other questions? Thank you, guys. Is there anywhere to watch review on this? Yes, on our Facebook group, which you can scan this code and join our Facebook group. You can also join us on our YouTube channel, but the recording will go there as well. Is there a list of schedule of reviews? Yes. So if you go to our website, so if you scan this QR code, maybe I should have a QR code that just goes to our website directly for future webinars. You guys are making me think about that. So if you go to our website directly at archerreview.com FNP, you'll see all the packages, and included in that is going to be a list of our webinar schedule. So if you scroll down a little bit on that page, you'll see all of our webinars scheduled for the next couple of weeks. But maybe I'll start adding a QR code. We used to have a QR code for the free webinars that you could just go on there and register. Maybe we'll start doing that again. All right, don't see any other questions on Instagram or TikTok. Thank you, Oriane, for joining us today. Thank you, everyone, for hanging in there. I know we went over time. I really enjoyed talking to you today. I'm not seeing any other questions. All right, you guys, have a wonderful Friday, rest of your Friday, and a wonderful weekend. I'll see you at the next free webinar.